Thanks everyone for attending our Sit-in Diagnostic Error Journal Club. And I would like to welcome everyone for today's Journal Club. Just to give you a brief about who I am, my name is Ahmed Hassoun, and I'm an epidemiologist at the School of Public Health and a member at the Center for Diagnostic Excellence at the School of Medicine. And by training, I used to be a musician, then a physician, and then a public health professional. Today, we are fortunate to have Dr. Andrew Solomon presenting today about the tension between early diagnosis and misdiagnosis of multiple sclerosis. Dr. Andrew is a neurologist at the University of Vermont Medical Center and an associate professor and division chief of multiple sclerosis, and the Department of Neurological Sciences at the Larner College of Medicine at the UVM. In addition to providing care for patients with MS, his research has focused on the evaluation of novel methods to improve MS diagnosis. Next. And his present projects, including the investigation of a novel MRI techniques and blood biomarker for the diagnosis of multiple sclerosis, in collaboration with the Translational Neuroradiology Section at the NINDS and Cleveland Clinic, University of Pennsylvania, Michigan State, and Vanderbilt University. Next. Now on to today's presentation, the tension between early diagnosis and misdiagnosis of multiple sclerosis. Welcome, Dr. Solomon, and thank you for presenting today. We will now turn it over to you.
Okay, thank you so much for having me.
Welcome.
Okay, thank you again for having me. I really appreciate being here. I realize I picked a somewhat unusual, maybe, article, it being a review article. I haven't given this presentation to non-neurologists before, and I felt that a lot of the data out there wasn't very scientifically rigorous, and I thought it'd be more interesting for you all, for me to present sort of an overview of this problem and encompass some of the recent data and some of the studies that I've done in this field. So I'm going to move on here. So I have some disclosures, I've done some consulting, I have some funding from Biogen. I always like to put this up there when I give talks about MS misdiagnosis. I've misdiagnosed patients as well, and whenever I talk about this, it's not meant to imply that not everybody makes mistakes, essentially. Okay, so here's what I'm thinking. So I'm going to talk very, very briefly about what MS is on topics covered in the Nature review. Published in neurology regarding MS misdiagnosis, which is discussed extensively in that paper. And then I'm going to get to how we diagnose MS and causes of misdiagnosis as far as we can speculate from the data we have, and leave a lot of time for discussion. So let's start. So what is MS? This is my one slide here. So MS is the most prevalent chronic inflammatory disease in the CNS. Approximately 1 in 400 risk here in Vermont. Second to motor vehicle accidents, is the most cause of CNS injury in young MS. It's clinically and radiographically heterogeneous, so there's a large number of diseases that can mimic MS. It has a variety of presentations. The phenotype is quite variable. What causes MS? Well, we have at least 200 genes associated with MS from GWAS studies, these genome-wide association studies, and most of those genes are implicated in the function of the immune system. MS is an autoimmune disease where the attack or the antigen is the central nervous system, the brain and the spinal cord. So there are a number of risk factors, environmental risk factors that we've identified that increase the risk of MS. So if you have identical twins, there's only a 30% concordance for MS. So environmental factors are incredibly important as well, and most of those factors seem to influence immune function. So it's an autoimmune disease that you have a genetic predisposition and you have the right environmental triggers and MS happens. MS is characterized by these episodes of neurologic disability. We call these relapses or attacks. Some people recover from these attacks and some people don't recover fully. These attacks can affect anywhere in the central nervous system. Again, that encompasses the brain, brainstem, and the spinal cord. And so people can have a variety of symptoms, disabling symptoms, numbness, tingling, weakness, difficulty walking, trouble with vision that can be transient, and they can be left with deficits as a result of this. This is the inflammatory aspect of this disease. There's also a neurodegenerative aspect of this disease, and some of that is linked to neuroinflammation, and some of it seems to be a result of it, or maybe independent from it. So some people, after a period of time, develop a progressive clinical course where they have subtle progressive ambulatory difficulty, for instance, or cognitive impairment. And we're still working out what some of the causes of that neurodegeneration are, but some of it certainly is linked to damage that happened earlier in the nervous system. There's no cure. We have these disease-modifying therapies, or DMT. They're immunomodulatory therapies, and they alter the early course of MS, so they prevent these attacks or relapses or all this neuroinflammation. We think it may also alter this progressive aspect of the disease as well, but that's clear early. It's not as clear later on in the disease when people are in their 50s and 60s. But the earlier we treat, it seems like we are able to prevent disability in patients. And again, this is a lifelong disease, and a lot of patients are diagnosed in their 20s and 30s. And most germane for our talk today, we don't have a highly specific and sensitive biomarker, but we have some diagnostic criteria since the 1960s, and those have evolved. And I'm actually going to get to those later. I'm just going to try and impress upon you the problem of misdiagnosis first, and then we'll talk about how we diagnose it. So by way of introduction, misdiagnosis. So there's a nice quote in this Oliver Sacks book I like to show people. This is his autobiography. So he mentions here, I'll just read this. These brain cuttings were very popular sessions which attracted, among others, clinicians eager to see if their diagnoses held up. So these are autopsies that are done on patients who have been deceased, and they're teaching sessions. He said, on one memorable occasion, we examined the brains of 5 patients who had been diagnosed in life as having MS. The brain cuttings, however, revealed that all of them had been misdiagnosed. And this, to me at least, highlights that MS, that misdiagnosis is often lifelong and can be really devastating. Similarly, a more contemporary example of this, we have a therapy called natalizumab, which was found to cause a potentially fatal brain infection. And this is from the New England Journal. This is the first report of this brain infection in this new medication. I believe this was in 2006. And this patient died as a result of this infection. They were in a clinical trial for this new MS therapy. And if you look carefully at the report, it's not the purpose of the report, but if you look carefully at the report, the autopsy didn't reveal any brain lesions that were compatible with multiple sclerosis. A lot of us feel like this patient probably didn't have MS, which is certainly devastating. This was a patient in a clinical trial for new MS therapy who died as a result of exposure to that therapy. So taking a step back, how often does this happen? How often is MS diagnosed incorrectly? So again, I'm sorry, I should have said I'm focusing on patients who are incorrectly assigned a diagnosis of MS, not the flip side of that, where patients are delayed in having the correct diagnosis of MS made. So how often are patients incorrectly diagnosed with MS, given the diagnosis incorrectly? So we have this referrals data, so not great, but we have something here. So this is an MS clinic in Nova Scotia. This is way back in the 80s, where they looked at 400 patients who were referred for MS, and 13% did not have MS. Now, the problem here is making a claim of misdiagnosis is not really tenable because we don't really know why they were referred or how many people had the diagnosis of MS that were referred. I'm sorry, I'm getting an echo somewhere. There were 30 alternative diagnoses, which demonstrates, the majority of these patients had psychiatric disease and migraine. Those are the top 2, and I'll get back to that later. We had a similar study in 2005 in Colorado. 67% of 281 patients referred to an MS subspecialty center did not have MS ultimately. 37 alternative diagnoses were given to these patients. Again, interestingly, psychiatric disease and migraine were up there as the most common diagnoses. I'll get back to that. We had a recent study in the Middle East. This was a number of MS centers in the Middle East, a well-known MS specialist who moved back there from Boston, and among others, 30% of almost 600 patients referred did not have MS. This is just in 2017. The most frequent, there were many diagnoses that were made in these patients, most frequent psychogenic or conversion disorder, some MRI diagnoses, migraine is here again, systemic autoimmune disorders. Now, again, these are referral data that, it's hard to make a claim, even though people have, that all these patients were misdiagnosed. because we don't know why they were referred. They could have simply been referred for evaluation for MS, and there could have been diagnostic uncertainty in these patients. But it gives you a sense, at least, of what diagnoses may be mistaken by MS out in the community or by other neurologists. We have some little bit better data. Again, some of it's quite old, but these are patients who had a diagnosis of MS, or unfortunately, we used to have something we called possible MS, which actually had diagnostic criteria. So this was in Boston. They looked through their records from 1948 to 1956. They looked at 660 patients who had either MS or possible MS, and 12% had been incorrectly diagnosed with those labels. Actually, at Johns Hopkins, there is some data from the 70s. So 9% of 211 patients, when they looked through, with MS or possible MS, were misdiagnosed. In the 80s, there was a similar record review somebody did, 387 patients, 17% did not have MS. Again, the problem here with some of these is it's really hard to say if all these patients were actually incorrectly diagnosed with MS. Similarly, there was a well-known MS specialist in the 90s who looked through all of his patients. There were second opinions sent to him, and 35% of them did not have MS out of 366. Again, a little uncertain how many had actually been given a diagnosis of MS before. So gold standard, we do have a pretty good study though in 1988, autopsy study of 518 consecutive patients in Denmark, and they died with a diagnosis of MS. Sometime between the 60s and the 80s, and the diagnosis was incorrect in 6%. So this is helpful. They had brain tumors, a lot of them, and a variety of other neurologic disorders. Again, this demonstrates that in these patients anyway, MS misdiagnosis persisted for life, unfortunately. The problem is that there remains no biomarker, and there was none in 1988, and so the study is able to distinguish demyelination, which is typical of MS, from other causes, and this also precedes our use of MRI, which is a big part of our diagnosis of MS and hadn't been in use at that time. So I got interested in this, and in 2012, I simply sent out a survey to, I think it was like 122 MS specialists, and I asked them, have you evaluated a patient who carried a diagnosis of MS for a year or longer? So they had to have at least a diagnosis of MS for a year or longer, who they then subsequently evaluated, and they strongly felt did not have MS. So this was in 2011, I think this was done, and 95% of these MS specialists said yes. Obviously, there's a lot of recall bias here, but I said, why don't you guess how many similar patients you've seen in the last year who you strongly felt didn't have MS and carried that diagnosis for a year or longer? And people kind of remembered quite a few patients. I think it's hard to know if this is accurate, but regardless, it's quite common problem was what this established. So probably the best data we have, and this is sort of like hot off the press or however you want to describe it, this has not been peer reviewed, and this is a study I got to be part of by Dr. Casey at UCLA and Cedars-Sinai. Dr. Casey is an MS specialist, and she reviewed all referrals to those two MS subspecialty centers for a year. And we had a pretty clear set of guidelines to establishing who had a diagnosis of MS to start with before they were referred over. We didn't accept ICD-9 codes or just comments. We really looked at referrals and what was said in the referral records and so on. So we tried to limit this study only to people who had a pre-existing diagnosis of MS. And so after their evaluation, 17% at UCLA and 19% at Cedars-Sinai were informed that they did not have MS. I guess the average is 18%. So that's impressive, and I'm not surprised by this data. Obviously, there's all sorts of biases here. This is a referral center. This is only in California, and there's certainly selection bias and referral bias and hindsight bias play here. We also looked at people who were referred for a question of maybe MS, and which is a different reason to refer people. And the majority of those patients didn't have MS. If you look down at the bottom there, 79%, 75% at each center. So what are some of the consequences of MS misdiagnosis? So a year or two ago, I wanted to see with a pilot study if we could just collect a group of patients who've been misdiagnosed. Again, this was before Dr. Casey's study that I just mentioned that hasn't been published yet. So there were 4 centers we got involved. It was us here, Vermont, Mayo Clinic, Washington University, and OHSU. These are all MS subspecialty centers. I created a REDCap database so people can enter data online. And we just asked everybody, we set up criteria for deciding if somebody had a misdiagnosis. And we asked everybody, over the course of about a year to enter data on patients who they determined to have been incorrectly diagnosed with MS. Now, I don't have time to go through all the details, but all 108 patients were informed at the time of their evaluation that they did not have MS in spite of their prior diagnosis. In the study, 1 patient had died and their misdiagnosis was discovered at autopsy, unfortunately. And 1 patient, there was a subsequent visit that was coming up. But all of these patients, there was no question that they did not have MS in the mind of the MS subspecialists who saw them. And we did try to set up some stringent criteria to decide that they actually had been diagnosed with it prior to the evaluation. So this is how long these 110 patients had been misdiagnosed. You can see quite a few have been misdiagnosed for 3 years or longer. Some have been misdiagnosed, unfortunately, for 10 or 20 years or longer, which is really bad, obviously. So here's some more information. 85% were women in this study of these 110 patients. Mean age was 49. Who misdiagnosed them? That's kind of interesting. So 24% were initially misdiagnosed by a neurologist with MS fellowship training, so a subspecialist, which is maybe not what people would expect. 32% were misdiagnosed with MS by a neurologist without any MS subspecialty training, and the majority of them we couldn't really sort out the training of the referring neurologist. But I think that's important. So we all make mistakes here. What else? So 70% of these 110 patients who were incorrectly diagnosed with MS received disease-modifying therapy for MS. 24% of those received disease-modifying therapy with a risk of progressive multifocal leukoencephalopathy. This is a frequently fatal brain infection. A fair number of these patients also received disease-modifying therapy for years or a decade or longer. So there's a lot of unnecessary risk here. I asked a specific question in the study from there were 23 MS subspecialists who participated in the study at 4 institutions. And I asked a specific question, was there an unnecessary morbidity as a result of this misdiagnosis in this patient? And the feeling was that in a third, that was the case. And when I looked at what was listed, it was primarily risks or side effects related to the disease-modifying therapy for MS. 4 patients who did not have MS participated in clinical trials for MS therapies of these 110 patients that we were able to identify over that year. One of them had conversion disorder, one of them had moya disease, I think the other 2 had migraine. We asked a simple question, was there clear evidence in your mind of an earlier missed opportunity to make a correct diagnosis? In the majority of cases, MS subspecialists felt there was. Again, that's hard to know, with hindsight bias. I really want to highlight the cost here. We did highlight that in that article that I share with you all. So the average wholesale cost for disease-modified therapy for MS is about $80,000 a year. And you can see over here that these patients were on these medications for a really long time. So the cost is, maybe hundreds of millions of dollars after you factor in MRIs and visits and, not even thinking about the risk of a fatal brain infection. So tremendous cost to our healthcare system. Going back to the survey, this was a 2012 survey where I said, do you remember seeing anybody who'd been misdiagnosed? What were the diagnoses? We tried to ask people to remember. These are not, quantitative data. We just said, what do you remember? And these are the top diagnoses that people remember having been mistaken for MS. This was, again, in the survey. This is not the 110 patients I just talked about. Again, what I want to highlight here, migraine, psychiatric disease, fibromyalgia, some non-specific brain MRI findings due to hypertension or ischemia were quite common. This is neuromyelitis optica spectrum disorder, and this has a highly specific biomarker. It's a demyelinating disease. Migraine and psychiatric disease popped up as the number 1 and 2 referrals for MS centers I showed in earlier slides. So the point here is that there's a lot of disorders that can mimic MS, hundreds, but there's a lot of common disorders that seem to be mistaken for it and stuff we should be able to diagnose. 2016 study, this is the 110 patients who have been misdiagnosed or incorrectly diagnosed with MS, what were the top diagnoses? Migraine, in combination with other diagnoses at times that were MRI diagnoses, like small vessel ischemic disease, fibromyalgia. This is not kind of a wastebasket diagnosis, unfortunately, but people with kind of numbness or tingling that didn't localize to the nervous system logically in an abnormal MRI, conversion disorder in 11% of patients, and this neuromyelitis optica spectrum disorder, which has an antibody test we can send. So this lines up nicely with all the other studies in some ways. You know, that migraine and conversion disorder in particular, and some of these other disorders are frequently mistaken. This is like 66% of all the diagnoses in those 110 patients. And we found a lot of other things, and here they are. And certainly things that are very rare. This is a diagnosis called, you know, Caterpillar Behçet syndrome, which I've never seen in my life. There are mitochondrial disorders here, neurosarcoidosis, moyamoya disease, which are very hard to diagnose, paraneoplastic syndromes. But you know, thinking about what I just presented, the point is that there are quite a number of clinical diagnoses that shouldn't be mistaken for MS. Last piece of this here, in that 2012 survey where we talked to 120 or so MS specialists, 2/3 felt that disclosing a misdiagnosis of MS was harder than giving a diagnosis of MS in the first place, which is not surprising. But what I worried about, and which turned out to be the case, was 14% said they sometimes chose not to disclose a misdiagnosis of MS to a patient who had been misdiagnosed by somebody else. And this problem actually is you know, something I thought about a lot. David and I tried to work on some administrative data type studies looking at MS diagnosis and the removal of a diagnostic code, you know, among, you know, thousands of patients to determine who had been initially diagnosed and misdiagnosed. But unfortunately, a lot of neurologists have trouble undiagnosing patients with MS. Why is this? This seems a little shocking, maybe. So, and I have an article on this, but seems like some physicians are worried they're going to hurt patients. They feel like there's an ethical dilemma here that if they remove this diagnosis of MS, patients are maybe psychologically invested. They worry that their disability benefits may be removed, which is not the case in the United States if you have another disabling syndrome, as far as I know. A lot of patients have this, you know, support groups. They have a strong identity associated with MS. They're worried they're going to harm them. Obviously, these harms complicate diagnosis, and undiagnosing MS, but they don't justify withholding information. And certainly, there are a lot of benefits to disclosing you think somebody's been incorrectly diagnosed, including the treatment of their correct diagnosis and a trustworthy relationship. So that's my kind of whirlwind tour through MS misdiagnosis. I'm going to try to explain as best as I can to presumably a group of people who may be non-neurologists, some of you, how we diagnose MS and why this is a problem. So there was just a new diagnostic criteria that came out, I think it was in January or actually in December. These are the steps to making a diagnosis of MS. We have to identify a clinical syndrome typical for MS, related CNS demyelination. This really includes a handful of syndromes: optic neuritis, brainstem syndromes, and transverse myelitis, which is inflammation of the spinal cord. Second step is to document that somebody has objective evidence of a lesion in their central nervous system on neurologic exam. And then we've got this criteria, once we do that, where we have to demonstrate that there's dissemination in space. What that means is basically they have disease activity in different parts of the central nervous system. So in the brain or spinal cord, different areas. And there's different ways we can do this. So recently, as MRIs become incorporated into our criteria, we can use MRI to say, you know, there's involvement of sufficient number of areas to meet this dissemination space criteria. Whereas before, with our criteria, which have been validated in the 90s, we had to wait for somebody to have a second attack. So that would involve their eye, and then maybe it would involve their spinal cord. And we could say, okay, well, there's dissemination in space. And we also need dissemination in time. We want to make sure this is not a monophasic syndrome. So they have to have changes over time to suggest that there's ongoing disease activity. So again, 2 attacks. But the other way of doing this is by using MRI. So if MRI shows changes over time, we can use that instead of waiting for a second attack. Now, the last part, all these parts are problematic, but the last part is no better explanation. So once you get to this step here, once you've fulfilled everything above, and you have somebody with a typical syndrome for MS, you have a dissemination of space and time, and you have an objective evidence of lesions on their neurologic exam, then you make sure that they don't have something else that could mimic MS as best you can. There are no red flags for other disorders. Now, this diagnostic criteria was validated in very specific, narrow cohorts of patients who have a syndrome typical for MS. And those cohorts have been kind of looked at as the criteria has been revised, and the new criteria are applied to these cohorts of patients over the years. So this hasn't been a criteria where it's been applied in patients with atypical syndromes. I'll leave it at that for now. So this is sort of what our diagnostic criteria may look like. Now, a lot of the manuscript for our diagnostic criteria explains how it was validated and what patients it should be used, when to worry. But it's all like this. It's all in these little captions below tables, right? But when our MS diagnostic criteria gets disseminated by the National MS Society and put on these little handy cards and goes out to neurologists around the world, none of those caveats are on there. All we've got is just, you've got a couple lesions, you've got objective evidence, and so on. So a lot of people are not as familiar with the diagnostic criteria as they should be. And our differential diagnosis, this is just one of our most important papers on the differential diagnosis of MS. There's hundreds of disorders that can mimic MS. I'm just showing this quickly. So it's really important not only to know how the diagnostic criteria works, but once you satisfy it, to make sure that there's nothing that's a red flag that would kind of alert you to an alternative diagnosis. The diagnostic criteria has about like 80–90% specificity for MS when applied in the right people. So why is MS being misdiagnosed? I'm almost done here. So we looked at those 110 patients, 4 centers evaluated by 22 MS specialists, and we asked them very specific questions about what we suspected was going on. In 65% of those misdiagnosed patients, there was an inappropriate application to MS diagnostic criteria of symptoms that were atypical for demyelination related to MS. So providers were having trouble determining what was typical, or they didn't know that the MS diagnostic criteria couldn't be just applied to anybody with any neurologic syndrome. In almost 50%, people used a historical episode, the providers who made the misdiagnosis used a historic episode of neurologic dysfunction without any exam findings to say it must meet dissemination in time. So what this means is I show up, I have a neurologic symptom, and I tell you, yeah, a few years ago I had blurry vision or something non-specific, and somebody says, okay, well, you have MS because you had 2 attacks, but there's really nothing objective about your optic nerve that substantiates that. And so that's a problem. There's a lot of details in our diagnostic criteria specifying how to think about people who had something in the past, but it's not happening. What else? Our dissemination space criteria. So again, this is something where we have to see changes in different parts of the brain or spinal cord or central nervous system. We specify how you can meet that criteria, and there are lesions called juxtacortical next to the cortex or periventricular next to the ventricle. And a third of these patients were incorrectly diagnosed. The lesions were kind of close, but they weren't actually touching these areas. And it seems that providers don't realize that that's our criteria. Overall, there was, in a majority of patients, this over-reliance on the presence of MRI abnormalities that meet dissemination in space. So people have lesions all over their brain, but the patient has non-specific neurologic symptoms. They don't have symptoms specific to MS. And our diagnostic criteria only work in patients with a clinical episode that's typical for MS, but people are applying this criteria to anyone. So in some ways, this is what's happening. Abnormal MRI, this could be migraine, this could be MS, this could be a lot of things. Any neurologic symptoms, and they're applying our diagnostic criteria. We have data that migraine, if you just look at the MRI, can meet our MRI diagnostic criteria, but that's ignoring the clinical syndrome. MRI criteria alone were not developed to differentiate MS from other conditions. Lots of other conditions can meet our MRI criteria. We can only use the MRI criteria once you've identified a typical clinical syndrome, which people seem to have trouble with. So last slide or so, over-reliance on misinterpretation of MRI abnormalities in the setting of atypical syndromes, unverified prior symptoms. That's right now what we think causes a lot of misdiagnosis. we have a lot of data that the earlier you treat, the more important it is. So there's this urgency for physicians to get people on these disease-modifying therapies and make the diagnosis. I would say the majority of syndromes that are mistaken for MS right now are common disorders, and they don't have a biomarker. So we still need to rely on our clinical skills. We're not, MRIs don't make the diagnosis, physicians do, and thinking does. To make the right application of MS diagnostic criteria in the right patients. This is not confined to non-specialists. MS subspecialists apparently also make this mistake, or maybe I think part of the problem is they accept a prior diagnosis from referring physicians without reevaluating it. I'm going to end there. I think I'm about at 20 minutes or so and take questions. Thanks.
No, there's other colorful ways of doing so.
Just ending tonight.
Thank you very much.
Sure.
He just took it upon himself to start doing it.
So we open the floor now for questions.
Yeah, so I stopped those. Like I saw them come through. It was like 2 shares of full.
Anybody have questions or type of question?
I have a few questions, but I will wait for the.
Oh, okay. Okay.
It's Dave. This is Dave Newman-Toker. Hi, can you guys hear me?
Yes.
Great presentation. Thanks, Andy. Love the work that you've done. Maybe I could ask from the sort of a high altitude perspective, a couple of intriguing questions that occurred to me as you were talking. The first is, we tend to think a lot about diagnosis, misdiagnosis of lethal illnesses of one sort or another, whether they're acute or subacute, chronic, like cancer, and so on and so forth. We probably spend less of our time overall at the national level thinking about this sort of chronic condition misdiagnosis, although we clearly know that there are plenty of patients out there who have this sort of diagnostic odyssey journey stuff. But my first question is there anything that you've learned from this that makes you think there are some important generalizable concepts about how to think about chronic misdiagnosis, if you will, that differ from this issue of acute misdiagnosis, either from a measurement standpoint or a research standpoint, so on and so forth? And that's question one. And question two is, this is a beautiful example of how you don't have a perfect gold standard, so you have these sort of criteria that sort of migrate over time. And I'd love for your reflections a little bit on what the implications of this are for sort of that whole broad range of diseases where we sort of, it's a moving target. We define diabetes today as one thing and tomorrow it's something else. And then we define hypertension as one thing and tomorrow it's something else. And kind of how that fits in your mind in the whole sort of misdiagnosis space.
Sure. Was there a number 3? I thought there was
no,
3.
there was just two's enough.
Two's good. Okay. Sure. So the first question was thinking about this as a chronic misdiagnosis. So I think there are a couple of things that come to mind immediately. So number one, unfortunately, I've also been involved in a number of legal proceedings surrounding MS misdiagnosis and physicians as a result of my work as well. So I've seen actually quite a number of cases of what I would consider really egregious misdiagnoses, in addition to some of the work I presented here. And one problem that shocked me was just the willingness to accept a prior diagnosis of MS without reevaluating it. And we don't have any guidance, in the literature on how to how to do that. Our diagnostic criteria is developed for somebody who shows up with an attack, and making that diagnosis when they have symptoms. But over time, sometimes the MRI can change and lesions can all blend together. Somebody's neurologic exam can improve. And so somebody shows up and you don't have adequate records. They tell you a story. You have, some records. And some physicians are just much more rigorous about confirming, at minimum, there's some evidence suggestive of MS other than a non-specific abnormal brain MRI and some not vague neurologic symptoms. So it's really dangerous. I've seen this a lot where, patients transfer care quite often. And I think this is where especially MS subspecialists, some of them, as well as providers, general neurologists out in the community can get in trouble, somebody just transfers in. Now, I think what's happened is also the stakes are different now. So until 2008 or so, 2006 or 7, most of our disease-modifying therapies were not fatal. They had minimal risk, the injectables that we used. So I think there was a tendency of some people to put patients on it, even where the diagnosis was uncertain, but feel that there's not, what harm is there? Maybe it's MS, I'm not really sure, but at least they're protected. And maybe there was time to reevaluate, the diagnosis. Because in some patients, that's what you need is time. And the problem is there's this urgency of starting these disease-modifying therapies. Now, virtually all of our new medications have very serious risks. They have this fatal brain infection. They have autoimmune disease generation, new autoimmune diseases, cancer, other serious infections, liver toxicity, all sorts of stuff that can cause serious morbidity or mortality. And but I don't know that people's practices have necessarily changed, to accommodate those new therapies. So there's more urgency in making sure that the diagnosis is correct, but because of these medications, but there's also urgency to put people on them. So I don't know if that's getting at what you're talking about, but I guess those are the things I think about, is that the stakes have become higher now in this disease, whereas before you had a chronic diagnosis and it was okay to have some uncertainty while someone's on medication, whereas now it's really not okay for some of these medications, and unless you have a really strong suspicion that it's MS. The problem with transfers of care over the course of a chronic disease with inadequate records and this disease changing over the lifetime of someone, the risks get much higher as people are older on these medications, and it gets much harder to verify a prior diagnosis of somebody who's diagnosed in their 20s when they show up and they're in their 50s and 60s. Yet they can be on these very risky therapies. So those are my initial thoughts about this being a chronic disease and some issues. The implications of the diagnostic criteria changing over time. The changes from 2001 to 2000, it's changed every 5 to 7 years. And since 2001, since the incorporation of MRI, and it's actually made the diagnosis of MS much easier each time in the appropriate patients. I think the problem is that I've never seen sort of like a really concerted educational effort with the publication of each diagnostic criteria on the part of MS societies, pharma, anyone, to get out and reach people to explain how to properly use the criteria. And that's the problem. And this starts during residency, hopefully, when people are in training. But as the criteria change, there needs to be education about how to use it. And it's just very, very frequently applied in patients where it was never tested. That's the main problem out in the community, is people don't know how to use the criteria properly, or even just there's several layers. There's who to use it in to begin with, and then once you decide who to use it in, what each term means. Thankfully, this new criteria has a glossary of terms, which has never been in the criteria before, defining some of the key terms that people should be knowledgeable about when they use it. So that's an improvement, a huge improvement actually. But then, the number of people who actually read it compared to the little cards that they get that are cheat sheet is a problem. So I don't know how to fix that. I'll stop there.
That's great. Thank you. Those are great answers. I'll ask one quick follow-up and then
Sure.
let other people ask questions. You mentioned pharma hasn't made any efforts. Do you think that pharma has a disincentive to educate people on the proper use of disease-modifying therapies?
That's a good question. Certainly they're making a lot of money. Maybe. I mean, these patients are getting into their trials, and I would think that should be an adequate incentive. Patients who are not, do not have MS are getting into trials for MS therapeutics, and I don't know the numbers yet, but clearly could affect the results or influence the results. They'll do probably pretty well. So, depending on what their diagnosis is, it depends. But if they have migraine or something like that, there are hundreds and hundreds and hundreds of speakers bureaus presentations every year by multiple pharmaceutical companies that have a stake in MS, and there are many. There are, I think, 17 disease-modifying therapies for MS now. There's a lot of companies involved in this field because it's so lucrative, unfortunately, or fortunately, depending on how you look at it. But I would like to see them. Most of those talks are about using their drugs, right? And it'd be nice if those are the talks that reach providers out in their practices and private practice and out in the community. I really think that, based on the data we have, that maybe 1 in 10 patients, out there who have a diagnosis of MS in this country, probably somewhere close to that number don't have MS, and that's pretty shocking.
Super, thank you.
Sure.
I have 2 questions actually. Excellent presentation. If we take a step back, most of what you presented is about overdiagnosis of MS or mislabeling a non-MS as an MS.
Right.
If we take a step back and look at population at risk, and the first step of coming up with the label of MS to that patient, and then the third one is wrongfully putting that step. So it's a false positive. It is the main problem that you identified. Do you know if the false negative is high as well? Looking back at the original population at risk.
Yes, it is. So the problem is, so you're asking, are patients with MS given other diagnoses incorrectly for a period of time before they get the correct diagnosis, right?
And vice versa. Those who had the other condition there that are more likely to be misdiagnosed as MS, did anyone study if those people were actually corrected back to MS?
I see.
If they were, yes.
Yeah. So there's a fair amount of very good data that shows there's a diagnostic delay in a significant proportion of patients who do have MS.
Okay.
There's a pre-symptomatic period where patients accumulate damage to their nervous system, and they may have fatigue or nonspecific symptoms, but they haven't had an attack yet. An attack is where one of these lesions in the nervous system hits something that causes them to feel something or have deficits, neurologic deficits, and then they see a doctor. Even at that point, somebody may misdiagnose their symptoms and not get the correct imaging modality or whatnot. So there's certainly a diagnostic delay. What MS is mistaken for, I don't know that there's a kind of a robust data on that, like what people kind of call MS before it's correctly identified as MS. I think that what I've seen, just anecdotally, is that often it's just that it's not neurologists as much as at the primary care level, where somebody may have what clearly to me is a spinal cord syndrome, but they're sent for a nerve test, and they're told they have sciatica, or like they get the wrong studies. Once there's some abnormality on MRI, a lot of cases it's pretty straightforward actually to make the diagnosis in people who do have MS. As I presented, the overdiagnosis problem is because of the MRI as well, because so many people get MRIs. I kind of highlighted some common syndromes like migraine, which can be hard to diagnose at times. migraine causes abnormal brain MRIs as well as, relapsing remitting symptoms. But there's a lot of features of migraine that would easily distinguish it from MS, and there are ways to differentiate it, by testing spinal fluid and doing spinal imaging and other things, which is not always done, quite honestly. And so there's a quickness by some neurologists to just kind of, once there's an abnormal brain MRI and somebody has some neurologic symptoms, there's not the pause there that there should be sometimes. Conversion disorder is notoriously difficult to diagnose. It doesn't cause abnormal brain MRI, but typically the patients have hypertension or diabetes or some other cause, smoking, of these little white spots on their brain MRI, and they're misdiagnosed with MS. But that diagnosis is hard to make. But some of the others, not so much. But the key is that a lot of those disorders do not have a highly specific biomarker either, with the exception of that other demyelinating disease I mentioned. I don't know of any cases where an MS diagnosis was taken away and then that was incorrect, where I haven't heard of anything like that yet. I'm sure it must happen occasionally, but there's often, as you can see with that study where we collected 110 patients, I mean, there's significant hindsight bias. Like, some of these patients have had this diagnosis for 10 years. In some cases, that there is a huge benefit to time and helping people clarify that it's not MS based on how things unfolded. And I can't get in all the details, but there's some very convincing history or neurologic exam or imaging findings or use or not use of disease-modifying therapy that can really clinch it, after somebody's, had this diagnosis for a few years. So so I don't think all these misdiagnoses are avoidable, unfortunately, but I think a lot of them are.
I just have one follow-up question. Do you think intervening at the delayed diagnosis or the mislabeling will yield the largest benefit on a population scale?
Yeah, that's tough. If we're thinking about cost, it's the mislabeling by far. And if you directed those hundreds of millions of dollars to people who do have MS, I would think there would be services or benefits that they could avail themselves of that might improve their care and prevent disability. So I think the mislabeling is a bigger problem, and is maybe a little bit easier to approach. Certainly, people are at risk for permanent disability if they don't have the correct diagnosis of MS early. But I'm not sure that's as easy to intervene on in the same way.
So in terms of feasibility and impact, that will weigh in more into the mislabeling. It's more feasible to correct, and the impact is more tangible.
I think so. By example, Dr. Casey, who had done this study in Los Angeles, which again has not been peer-reviewed yet, but we gave you sort of the preliminary data. In that clinic, they part of their initial intake note is to decide whether this new patient they're seeing meets our MS diagnostic criteria, and that's formally evaluated in a sort of in a structured way. And that doesn't happen everywhere. It doesn't happen out in the community. And so I think an intervention like that could be really impactful if it's widespread.
Thank you. Any other questions?
Yeah, I have a short question. Dr. Solomon said that current diagnostic tests for MS, are they good enough or better tests?
We're coming close to 4 p.m. almost. If nobody has a question, I actually have most of my work is on AI and machine learning. And do you think there is a role for AI and machine learning in improving the diagnostic process of multiple sclerosis?
Yes, I do. So I'm working on imaging techniques, you know, to better differentiate MS from other disorders. And if you take different aspects of the pathology or pathophysiology of this disease that are demonstrated by imaging, and I think it's sort of like a multimodal approach. I think that there's hope that we could have an MRI that or an outcome measure that could have a high, you know, we could screen a large population of people with abnormal brain MRIs and say, you know, how and deep learning or machine learning can be given, you know, here's MS, here's not MS, and figure that out. You know, there's people also working now. There have been many serum and blood biomarkers that have come and gone and have not panned out for MS. Again, partially because there's probably multiple antigens involved in MS, and there's, you know, hundreds of genes involved, and involves various aspects of the immune response. But there are common pathways, and there are people now looking at non-coding RNA and the expression of using machine learning of a variety of RNA seems to be like it could be promising as well. And I guess my hope is that we could combine, you know, some type of blood test with some imaging to really come up with something that's highly specific to begin with. And I think machine learning will be kind of key for that, actually. To clarify, all of these diagnostic criteria, I think I emphasize this, were validated in cohorts of people who presented with syndromes typical for MS with a high likelihood of developing MS. So we have nothing right now where somebody shows up and you could actually do a screening test. The physician right now is a screening test, and the physician has to decide if this patient who shows up has a typical syndrome for MS. And so to have some type of objective, you know, biomarker where we could just screen everybody is obviously needed.
So there was some work recently from IBM on the imaging, and they have been working on that for a long time. But after working on a few projects on imaging processing through deep neural network, the question that always come up by the team at IBM is, should we teach the network from the beginning about some of the logic from the experts, or should we wait for the results from the neural network and then filter these results based on the expert's opinion?
Right. So I don't know the answer. I think right now we should look at both approaches. Like you know, like the deep learning, you know, the Google and other groups. You know, I think it's interesting. You know, if you can give it a bunch of, you know, like hundreds of scans of MS, you know, clinically definite MS, and then it can learn from that, and you know, just based on the changes on that MRI, you know, it can potentially tell the difference between MS and migraine. You know, that would be interesting. But we have these new imaging findings on 7 Tesla magnets, which are not clinically available, you know, for routine use, that are now translating into 3 Tesla magnets, which are clinically available, where we have sort of a demonstration of the specific pathology of MS. So we have this thing we call central vein sign, where it looks like most of the lesions in MS are surrounded by a tiny vein, and there's a little vein in the center. That can happen in other disorders, but the proportion of lesions with that in MS seems to be highly specific. But right now it takes me or a postdoc to sit there and look at every lesion and look for that vein. So I'm working with a group at Penn to say, well, you know, can we teach a computer to look for this and decide that this is a central vein and see how well that performs? There's atrophy of certain parts of the brain, specifically the thalamus, very early in MS, and we haven't seen that in a lot of these other disorders. And so this is you know, based on pathology that we've known a long time, and we can automatically segment and measure the thalamus now. There's cortical lesions that are present in MS that we can sort of indirectly measure now, which are not present in other disorders. So by combining, you know, so thinking about what we feed into this, I mean, there are opportunities now where we can visualize objective findings and feed those in potentially into some algorithm and help differentiate MS from other disorders. You know, probably, you know, by virtue of the fact of having so many MRI visible pathologic features of this disease that are specific, we could develop some thresholds. It won't be perfect, but it would be a lot better than what we've got. That's my hope anyway.
Thank you.
Sure.
So we have actually 3 minutes left. A final question: if a young fellow or young students in the center would like to study diagnostic error in multiple sclerosis, what will be the best available data sets to start with for someone who's starting a career in that field?
That's a good question. I'm not aware of any.
Okay.
You know, I mean, so my goal in the next few years is to collect, you know, data on hundreds of patients who are referred for evaluation for MS in this center, collect, you know, new MRI acquisitions, study MRIs and blood, people who ultimately do have MS and don't, and, you know, follow them for a number of years. But that's what we need. We have no studies like that at all, as far as I'm aware. All these studies on diagnosis involve are like essentially retrospective cohort studies that are patients who, they don't contain patients who were not diagnosed with MS ultimately. They don't contain patients who have disorders that are commonly mistaken for MS. Some of them contain patients who had a monophasic demyelinating syndrome that has a high risk of becoming MS, and a typical syndrome. But most of the diagnoses I've spoken about are not part of those data sets. So that's where we unfortunately need to start, is to create them. Unless there's some registries, you know, it may be that, you know, a lot of the good medicine happens in Scandinavia, right? So,
yes.
You know, it may be that there are some registries in some of these countries of for these clinics. They definitely have registries for people who do have MS, but maybe they do have records of who is evaluated for MS at some of these centers. But I'm not aware of any such records in the United States. But it's possible, you know, in Iceland or some other country with you know, centralized healthcare. It could be possible.
Thank you. Well, thank you very much. It's 4 p.m. We would like to thank you so much for your time and for the excellent presentation. And we would like to thank everyone who attended today's Journal Club. Thank you all.
Thank you,
Super.
everybody.
Thanks so much. Thanks so much, Andy. Talk to you soon.
Okay. Thanks, everybody.
Thank you very much. Bye.
Bye.
Be a great session. So thank you all for joining us.